Bismillahirrahmanirrahim. It's a great pleasure to participate today. First, I'd like to thank Professor Ana and Professor Ines for giving me the opportunity to share my presentation today. Also, I would like to thank all the organizing committee and the chairpersons as well as my colleagues. Today, I'll give a simplified approach to diagnosis of inborn errors of metabolism in the neonatal period. First of all, for any neonatologist or genetist to have a simplified approach for diagnosis, there must be a background on the different types of inborn errors of metabolism. So first, they must know a concise classification of the different groups. The first group, intoxication disorder, for example, amino acidosis, organic acidemias, urea cycle disorder. The second group, reduced fasting tolerance, for example, fatty acid oxidation disorder. The third, disturbed energy metabolism, for example, congenital lactic acidemia. And the fourth, complex molecule, for example, lysosomal storage diseases. As disturbed the neurotransmission, for example, non-ketotic hyperglycemia. And very important for those disorders, there must be a nutritional as well as medical treatment, and the nutritional treatment play a major role in therapy because those patients do have a metabolic decompensation, and they need to have a good dietitian regimen for clinical nutrition must be present hands in hands with a genetist, and this is the cornerstone for treatment because those patients need special formulas throughout their life. This is very important for those patients. Before I go to have a simplified approach for diagnosis of inborn errors of metabolism in neonatal period, I want to stop shortly here for prenatal development. It's very important to know that toxic small molecules that accumulate in many disorders of intermediate metabolism don't harm the fetus. Luckily, the fetus is protected by his mother because they are removed via the placenta and metabolized by the mother. Newborn affected with such disorders usually have a completely normal intrauterine period and are born with normal birth measurement at term. This is most important. Those patients or newborn with inborn error of metabolism is born normally, most of them. Disorders that interfere with cellular energy metabolism, for example, mitochondrial disorders, they impair fetal organ development and prenatal growth, causing structural, in particular cerebral. The brain is the main organ affected, as well as dysmorphic features and muscle disease in the form of dystrophy. Disorders affecting the breakdown of complex molecules, for example, lysosomal storage disorder, those groups of disorders usually don't manifest at birth, with some exception, for example, mucopolysaccharidosis type 7, as well as infantile oxalic acid storage disease. Those disorders can present as birth with dysmorphic features. Because usually, if I do have patient, for example, mucopolysaccharidosis, they don't have the manifestation at birth like Down syndrome. Usually, if in the OR, after delivery, we knew that our patient is Down syndrome. If we do have a patient with mucopolysaccharidosis, we don't know that he does have the picture, except usually in the first year of life, between 9 months, usually manifestations at dysmorphic features. The mother usually come to us to say the baby was perfectly normal, then I started to have some dysmorphic features of my son. Disorders of intermediate metabolism, that is to say intoxication disorder, those are usually asymptomatic in the first hours of life, and neonates typically born after an uneventful pregnancy. Usually there is a hiatus. There is a hiatus, a period in which the baby born normal for 1 to 2 days until accumulation of toxic metabolites, and then the baby started to have symptoms. This is important in the history. Usually for any newborn or baby full term and then started to have deterioration or started to have sepsis-like picture, you have to suspect inborn errors of metabolism because unlikely patient full term who had 2 days or 3 days period of normal being and then start to deteriorate, most likely to be sepsis. This is unlikely. It is most likely metabolic disorder. They present after exposure to receptor substrate derived from the catabolism or diet, for example, in protein disorders such as urea cycle disorders or maple syrup urine disease. There must be feedings, whether artificial formula or the mother started to feed, then the start of symptoms appear. Patients with acute aminoacidosis usually develop progressive symptoms between days 2 and 5 of life. Carbohydrate metabolism, on the other hand, like galactosemia, usually present after introduction of milk. And those babies can have a catastrophic presentation. Galactosemia is the most common metabolic liver disease, which can be started even in the first week of life from ingestion of milk containing lactose. And this is very important because those babies, if we started early by screening or by screening of galactosemia, can be preventable. So very important for those babies to have regular screening. Disorders with reduced fasting tolerance also they do have manifestations after prolonged fasting, and this is important for those disorders. With the disorders of energy metabolism, usually can present at birth. For example, mitochondrial disorder, they can do have metabolic acidosis at birth. And disorders of complex molecule, as I said, they do have progressive organ failure. The clinical presentation of neurotransmitter disorder and related disorders usually depends on the oncogenic expression. For example, like non-ketotic hyperglycemia, those babies they started to have a seizure disorder from day one. For example, if I had another disorder like urea cycle disorder, it can manifest by seizure, but usually not from day one. Usually the mother will say, or the doctor will say, I do have 2 days, then seizure started. On the other hand, neurotransmission, if seizure day one, I have to suspect neurotransmitter disorder. There are even symptoms can be started in utero if they are severe. Inborn error of metabolism in neonatal period, very important the presentation. Important in presentation in neonatal period present in 2 ways: detection through universal newborn screening, and I got and this is hopefully will help most of the babies to be detected asymptomatically before the start of symptoms, and usually, inshallah, it will start to be like abroad. Babies will go, even if they went home, they will come to receive a telephone call that your baby's newborn screening result is abnormal and please start to have treatment. The second thing, this usually what we faced in most of our NICU clinic hospitals, that presentation clinically. That is to say, presentation by symptoms and signs, and usually because we are missing the diagnosis or we don't have clinical suspicion of inborn errors of metabolism. And very important, those patients are occasionally very sick, and we have significant morbidity and mortality if the diagnosis and appropriate management are delayed. Because very important time. I'm saying time is very important for metabolic disorders because we need a good clinical suspicion, because if there is delay from the diagnosis and the start of the treatment, it will affect the mentality and will have drawbacks on the patient cognition, and is the most important. I have a patient who received treatment later and who do have intellectual disability, and this is not nowadays feasible. For other metabolic disorders, usually in the neonatal period, presentation can be suddenly, gradually, or insidiously. Physicians need to have a high index of suspicion to think and to diagnose these disorders. Metabolic disorders should be considered in any sick neonate. This includes sick neonates with unexplained sepsis-like picture. Because very important, sepsis can be the result of metabolic disorders, and also metabolic disorders can present with sepsis. So very important, I have to have a link between them, and I have to do investigation parallel. Septic workup has to be done parallel with metabolic workup. The most important question most of us need to know when I suspect metabolic disorder.
Yeah.
History very important, as all of us knew that most metabolic disorders are autosomal recessive. So by history, we can find that parent are consanguineous, or you can find history of another seed who's affected by this metabolic disorder. Maternal help, which is hemolysis, elevated liver enzymes, as well as low platelets. They found the mothers who do have those manifestations, sometimes they do have metabolic disorder, especially in the child. So it is better if mothers do have this presentation, they do have to be screened for LHL, because sometimes they do, the babies have manifestations. History of several illnesses, especially in the sibling. This is very important. Unexplained neonatal death or sudden infant death syndrome, and this scenario most likely patient with fatty acid oxidation disorder. Sometimes the family give history of sudden infant death, and the most common cause of sudden infant death due to metabolic disorder, especially the first week of life, could be fatty acid oxidation disorder. There are some alerting signals. Clinical presentations, not useful in making diagnosis, but when observed in combination with our purpose, could be suggestive of metabolic disorder. Those symptoms and signs are non-specific, but they raise the clinical suspicion. First, like poor feeding, lethargy, vomiting. I will stop here in vomiting. Very important to know if I don't have a newborn for 1 week or 2 weeks of age and have projectile vomiting or severe vomiting, first which will jump to clinician that this baby had a pyloric stenosis. Very important to differentiate between metabolic disorder and pyloric stenosis, because for pyloric stenosis you do have hypochloremic alkalosis, whereas for metabolic disorders you do have high anion gap acidosis. And very important, if there is metabolic acidosis and high ketone, you have to think of metabolic disorder even if you palpate an oil. Anorexia, rapid deep breathing, compensatory respiratory changes, unusual odor like maple syrup, in case of maple syrup, urine disease, convulsion, coma, hypothermia, and apnea. Hiccup. Neonatal crisis cannot be differentiated from sepsis, and as I told you, very important, septic workup had to be done in parallel with metabolic disorder because this is a very important. Physical examination is the key to reach the diagnosis. There must be comprehensive and focused physical examination for newborn, as we all of us knew, from head to toe. We have to examine him completely for organs, for reflexes, for others. General condition of the baby may raise a suspicion of inborn errors of metabolism. Sick looking baby may suggest intoxication, especially in the presence of stigmata of encephalopathy, such as lethargy, seizure, hypotonia, and coma. The presence of dysmorphic features, as I said, macromolecule for lysosomal storage disorder, could give a clue for suspicion of inborn errors of metabolism. Eye examination is very important. I said that usually ophthalmology team is very important together with the metabolic team, because sometimes ophthalmological abnormalities give us a clue to metabolic disorders. For example, cataract. If we do have cataracts, it's usual for patients with galactosemia. Others, if we do have cherry red macula, we can suspect Niemann-Pick disease, and others. Abnormal order of the neonate is useful signs of metabolic disorders, and usually in the past, before the advent of newborn screening, the spread was done by many centers. For example, as I said, the maple smell for maple syrup, as well as sweaty feet for isovaleric acidemia. And even though sometimes in the clinic, a clever dietitian usually knew that his patient is not compliant to treatment when he came from, when the door is open and came to the clinic, oh my goodness, I hear the smell of the baby. This means that he is not compliant with the treatment. The kidney with respiratory acidosis, the sick newborn may suggest a urea cycle disorder, but very important, if I don't have alkalosis, I have to rule out urea cycle disorder. If I do have a normal newborn who deteriorates in second or third day, who does have coma, I have to do extraction for serum ammonia, even if the baby acidotic, not in respiratory alkalosis. Ammonia has to be done to rule out urea cycle disorders. Clinical evidence of cardiomyopathy. This is very important in neonatal period because many of the disorders, inborn error of metabolism disorder, are treatable. For example, if you found cardiomegaly and we raise a suspicion of fatty acid oxidation disorder, usually in combination with hypoglycemia, elevated CK, and usually Pompe disease. Pompe disease also, we need early diagnosis for those disorders because there is treatment by enzyme replacement therapy, which if started early have a good prognosis. Jaundice eating tendency and hepatomegaly may suggest metabolic liver disease such as galactosemia, tyrosine, and mitochondrial disorder. So, if we face with this baby, we have to do first line investigations such as blood gases, plasma electrolyte, plasma glucose lactate, plasma ammonia, CBC, bone profile, coagulation profile, and culture and septic workup, as I said. Then we'll move to second line investigation, and this investigation has to be done with a maximum for 24 to 48 hours, not more. And this has to be done in specialist centers who have a good experience in metabolic disorder to give us the result, because we need to save those newborn and we need to know the result as early as possible, such as acyl carnitine profile, right blood spot by tandem mass spectrometry, plasma amino acid quantitation, as well as urine organic acid and urinary orotic acid. This is very important differentiating point if you do have a patient with urea cycle disorder, because I'll tell you in the next slide, there is some disorder who do have the same biochemical amino acid abnormality, so we need to differentiate between them. There are some alerting signals also by chemical findings. If you find acute metabolic acidosis with increased anion gap, especially in the presence of ketonuria, we have to think of organic acidurias. If we do have hyperammonemia, also we have to think of urea cycle disorder. If we do massive ketosis, as I said, with metabolic acidosis, we have to think of organic acidemias, and also hypoglycemia, and I give you later logarithm for that. There is supportive things. We have to do chest X-ray. Sometimes those babies came with pneumonia or others. We have to do echocardiogram, clinical ultrasound, complete screening, including CSF examination. Sometimes it is needed for those patients. And then the third line investigation, those have to be done by a person who is clever or expertise in genetics. Sometimes all pediatrics. Sometimes there is a baby came, I do have the clinical suspicion, I have experience that this baby is going to have, for example, a non-ketotic hyperglyceminemia. So I have to do CSF and serum glycemic ratio. If I am seeking of peroxisomal disorder, I do very long chain fatty acid disorder, and also urine gags if I'm thinking of mucopolysaccharidosis. For those who have experience, for those, this is a third line of treatment investigation. This is a figure I want to tell you that if we do have a sick neonate, a term, or the baby could have a metabolic disorder, they could have other, due to trauma, due to infection, due to major electrolyte disturbance malformation. The most important for me is that first think of treatable disorder. This is time, as I said, this is the most important for all metabolic newborn. First, if there is neurological deterioration, that is to say, I'm saying the baby has coma or deteriorated in the consciousness level, they seem to be very quickly ventilated and deadened and so on. So I'm having to think of maple syrup urine disease, methylmalonic acidemia, and other organic acidemias also can happen to do have neurological deterioration, multiple carboxylase deficiency, and urea cycle disorder. If I do have predominant seizure, please think of a treatable seizure disorder in your newborn period. We have to think about pyridoxine, pyridoxal phosphate. Also, I have to think of folinic acid if no response to the previous two. And also, if I do think of jaundice, metabolic liver disease has to become like galactosemia. As I said, it's very important to think about it if I found the non-glucose reducing substance in urine, together with the positive criteria for hepatomegaly. Also, to think of other differential diagnosed like tyrosinemia type 1. For cardiac failure, I have to think about fatty acid oxidation disorder. Persistent hypoglycemia, I have to think of hyperinsulinemia, hypoglycemia syndrome, fatty acid oxidation disorder, and glucogenesis. Emergency treatment must be taken in parallel with investigation. This is the most important message I want to tell. Very important for you not to make things very hard. You have never give up. Just to think, just to say, I have a good clinical suspicion, I'm suspicious, don't be afraid. This is very important. I wanted to stop. I have some case scenario, and it would help us some period for diagnosis of such disorder. A 36-hour-old boy was referred for evaluation because of hypotonia, respiratory distress, feeding refusal, clinically unexpected neurological deterioration, polypnea, as well as dehydration, normal pregnancy and delivery, biochemically, metabolic acidosis, ketosis, hypernatremia, dehydration, hyperammonemia, and leukocytosis. What do you suspect? This is the differential diagnosis which came to my mind. I first think about sepsis, maple syrup urine disease, urea cycle disorder, NKH, as well as organic acidemia. So very important for differentiation between them, I have to ask 3 questions. First, what are the blood gases? Second, what is the CBC? Third, what are the uric ketones? If I do have primary metabolic acidosis in the presence of massive ketone and pancytopenia, I have to think of organic acidosis. On the other hand, if I have primary respiratory alkalosis together with uric ketone absent, pancytopenia absent, I have to think of urea cycle disorders. Result of second line investigation found a cytometry profile showing C3 positive as well as 3-hydroxypropionate. I have to think of organic acidemias, mainly propionic acidemias. Also, another case delivered 40 weeks, the baby at 3rd day, patient had seizure, everything was normal. After performing septic workup, the baby was found to have high ammonia. And also the same as I said in the previous report, I found that baby had high ammonia 1150 micromole per liter. I said plasma amino acids was really not detected, glutamine 1200, arginine was normal, argininosuccinate not detected, organic acid as well as orotic acid were negative. I have to think of urea cycle disorder, especially CBS1, which is carbamyl synthase 1. As I said, very important for differentiation between NAGS deficiency and CBS1 deficiency is with those patients you don't have the same plasma amino acid and the same orotic acid, which can be absent or normal. If we don't have suspicion of those 2 disorders, we have to do molecular testing. This is the only differentiating point between those 2 disorders. If I have another newborn with normal breastfeeding, they seldom refer to NICU because of boxing and bedding. This is very important for the boxing and bedding. And the baby does have some +1 ketonuria. I have the same the differential diagnosis, plus amino acid showing high leucine, valine, isoleucine, as well as most of DNPH. I have to think of what I have to think of newborn disease. Very important in newborn period, the presentation of those newborn by boxing or bedding. The mother will say as if he's riding a bike. This is very important for newborn with newborn disease. And this figure is very important when you have a neonatal coma. I have to do blood gases, ammonia, and electrolyte. If there is high ammonia, metabolic acidosis, think of classical organic acidemias and also organic acid as well as tandem. And if I do have no metabolic acidosis in the presence of high ammonia, I have to think urea cycle disorder, check amino acid and orotic acid. If I do have no elevation of ammonia and there is massive ketonuria, I think of macrocerebral disease. Also, I have to do tandem and urine organic acid. For also ketonuria, if not present, in the absence of all other items, I have to think of NKH. Very important thing for neonatal neurological deterioration, mostly metabolic, mostly treatable, and the characteristic amino acid or organic acid and acyl carnitine profile. Very important if we do have a newborn suspecting hepatic presentation, if you have hypoglycemia, hepatomegaly, I have to think of glycogenesis. As well as fatty acid oxidation. If I do have manifestations of liver failure, I have to think galactosemia. If I do have cholestatic jaundice, I have to think of bile acid disorder. If hepatosplenomegaly, I have to think of storage disorder, especially for Niemann-Pick and Gaucher and others. For cardiac, as I said, we have to think of fatty acid oxidation disorder. And very important for neonatal hypoglycemia, if we do have liver failure, we have to think of galactosemia, tyrosinemia type 1, recurrent intractable hypoglycemia, hyperinsulinism, hepatomegaly, normal glucose after infusion gluconeogenesis, and for if I do have cardiac sign, liver sign, elevated CK, we have to think of fatty acid oxidation disorder. In conclusion, inborn errors of metabolism constitute a group of inherited disorders that cause a significant neonatal morbidity and mortality. The diverse group of diseases present with different clinical manifestations that makes the diagnosis a real challenge. It is important for pediatrician neurologists to keep in mind on inborn errors of metabolism as a cause of illness in the neonatal period. Maintaining a high index of suspicion of metabolic disease in an neonate is essential, as many disorders are treatable, and in most cases, successful outcome is dependent on the rapid diagnosis through relevant investigations at the appropriate time and early initiation of therapy. Even with untreatable disorders, it is important to establish the diagnosis in the index case in order to allow prenatal diagnosis of subsequent pregnancies. And take-home message, don't miss a treatable disorder, don't miss life-saving treatment. Thank you.
ثانكس دكتور ولا خليفه، بجد يعني simplified فعلا امبور ايرور ميتابوليزم ابروتش دايجنوستيك ابروتش، وده بصراحه السمه العامه للمؤتمر كله. الدكتوره سناء والدكتوره انياس الله يكرمهم كلها ابلايد، كلها من الواقع المشاكل اللي احنا بنواجهها وازاي ابروتش لها، لان زي ما هي الدكتوره علا بتقول ان هو بيقلل الموربيديتي والمورتاليتي. انا مهم جدا ابروتش ايرلي ان انا ديتكت الامبور ايرور ميتابوليزم، افويد نيو ديفلوبمنتال ديلي، ان انا طفل بنتال ريتاردد وعيب على كل من الاهل البلد كلها. يبقى مين ثانكس فعلا دكتوره علا. الحاجه الثانيه ان احنا بنقول مش بروجنوزس ومانجمنت بس، ده فور جينيتك كونسلنج وبرينيتال دايجنوزس فور فارسال بريجننسي. Introduce another speaker.